Hello, everybody. It's my pleasure to welcome you to another ERKNet and ERA webinar. My name is Jens König from Münster, and I have the great honor to introduce our today's speaker, who is Professor Olivier Devuyst, who actually needs no introduction as he's one of the world stars of global nephrology. Olivier Devuyst is a full professor at the University of Zurich with a joint clinical appointment at Saint-Luc Academic Hospital in Brussels. He's a specialist in internal medicine and nephrology and an outstanding expert for inherited kidney diseases. Professor Devuyst and his group have been studying the mechanics of genetic kidney disease for more than 25 years. His work has led to decisive advances in the understanding of genetic architecture of kidney disease and the mechanisms involved, relevant to common diseases and to the discovery of new therapeutic targets. Olivier Devuyst has played a leading role in various European consortia, including Eurigene, Unephron, Urinomics, and he founded the Genetic Disease Working Group of the European Society of Nephrology, the ERA, and is involved in the management of the European Reference Network for Rare Kidney Diseases, ERKNet. His work was awarded several international prizes, including the Donald Selden Award for from the International Society of Nephrology and the ERA Award for Outstanding Contributions to Nephrology. Among many other scientific and political activities, Professor Devuyst has been coordinating the first global KDIGO guidelines for autosomal dominant polycystic kidney diseases, a project of massive dimensions and tremendous impact, and this is also the topic he will refer on today. I may remind you that you are, as the audience, are all muted, and if you want to raise any questions, please put them in the question box, and we will read them out at the end, and Professor Devuyst will answer them. Professor Devuyst, it's our great honor to have you here today, and we are very excited to follow your lecture.
Thank you very much, Jens. I would like also to thank Stephanie and the staff at ERKNet for organizing this presentation. I'm very glad to be here on behalf of the KDIGO team who worked on these clinical practice guidelines, and I will just share with you my slides. Okay, so I hope everything is fine. Yes, okay, good.
Yes.
So polycystic kidney disease is not recent finding, because as you can see from this thesis cover, it was discovered and described in a very detailed way already in at the end of the 19th century in Paris. And since then, of course, the time has flew, and there are lots of very important studies that have been published over the last 30 years. First, of course, the discovery of the two main genes for ADPKD, PKD1 and PKD2. Then the first clinical study started with the CRISP study, which established the total kidney volume as a very good indicator of progression. Then you can see on this cartoon several clinical intervention studies, everolimus, Tolvaptan, and then blood pressure corrections. And the progression in this knowledge led us to organize in 2015 consensus conference on ADPKD, and this consensus conference was a kind of preparatory work for a guideline. However, you know, at the time, 10 years ago, the evidence was not so strong, and it was difficult to have definitive recommendations on this on a strong basis. So over the last 10 years, the accumulation of data and studies on ADPKD allow us to think about a real guideline process. And this was driven by Vicente Torres and myself. We were actually working on that since almost 10 years, since the consensus conference. And we gathered a work group of 26 experts in the field, including patients, and it was a global effort associated with an evidence review team. And the document was then reviewed by the public. And you can see that we got more than 240 comments about this document. And finally, the guidelines and the executive summary were reviewed. Both documents were reviewed by KI and will be published in early 25. So as you are probably familiar with, the clinical guidelines come in two different types of statements. They are the recommendations, which are graded because they rest on strong evidence. And they are practice points, which are more expert consensus points, which in the case of genetic disease, of course, form the majority of the statements. Altogether, everything is included in 10 different chapters, and the whole scope of ADPKD is covered. And I just show you now the work of the evidence team was quite extensive. More than 1,000 articles were reviewed, and finally 238 studies were included in 6 chapters of these guidelines, leading to recommendations which are graded, as you know, level 1, level 2, with different letters explaining the quality of the evidence and numerous practice points. So this is the table of content of the full guidelines. You can see it will be out in February. So the guidelines is more than 200 pages. There are many tables and figures, supplementary files, 900 references, and a very comprehensive research agenda, which is very useful for the generations to come. This will be complemented by an executive summary with all the key points, which will be published in the main body of KI also in, I guess, January 2025.
Sorry, Olivier, to interrupt you. Is there anything we can optimize on the audio connection? Because the audio is not really good at the moment.
So you cannot hear me or what?
Yeah, it's very blurred pretty often, actually. It's probably the connection. Are you working with a headset?
Yes.
Oh, okay. Then it's probably the connection, and we unfortunately.
Yes. Maybe poor connection from Zurich. I don't know what can do more than that.
Okay, then let's just continue. Sorry about that.
Yeah, sorry about that. Okay, so as you know, ADPKD is relatively complex in terms of genetics. The two major genes, PKD1 and PKD2, have been discovered almost 30 years ago. But sometimes the other genes are involved, and their involvement has been confirmed, or the evidence is still relatively limited. Next to polycystic kidney disease, there is also polycystic liver disease, for which, again, two major genes have been identified, and minor genes have been discovered more recently with variable level of evidence. In between polycystic kidneys and liver, there are intermediate phenotypes. And for instance, in the middle here, you can see this is it's a PKD1, typical PKD1 mutation, but you can see that the cystic liver is preeminent and there are less cysts in the kidneys. Whereas at the bottom, you can see a typical liver, polycystic liver disease gene in which the kidney phenotype is also preeminent. Next to that, we have also kind of intermediate phenotypes or very specific phenotypes. In some cases on the left, you can see you have a few but preeminent, very large kidney cysts. You can have also at the right hand, you can have kidneys with a multitude of very, very small cysts. Fibrosis, the size is not particularly enlarged, and kidney failure is reached very late. On the contrary, you can have cystic phenotypes which are dramatic and very large already in childhood. So all these intermediate phenotypes with different genes involved are posing problems in the field, and this is why we decided to propose a new nomenclature to navigate this genetic heterogeneity in polycystic kidney and liver disease. And the new nomenclature is relatively similar to what has been proposed for autosomal dominant tubulointerstitial kidney disease. So, i.e., you put the clinical name attached to the gene that has been associated with the disease. Of course, this has to be PKD1 or PKD2 or confirm a minor gene. And in that case, you will have PKD/PKD1 or ADPLD/SEX63, for instance, when you are sure about the genetic causality. If genetic testing is not performed, or if the gene is a minor gene which is not very sure, or if the variant is not very sure, then you will restrict yourself to ADPKD like before. So this new nomenclature offers several advantages. First, it maintains the name ADPKD, but it will give some phenotypical characteristics associated with the causal gene. For instance, we know that PKD2 is less severe than PKD1. So if you put PKD2 to the name, you add some information. And also the inclusion of the causal gene will facilitate further clinical and epidemiological studies like for other genetic disorders. A new name has been very helpful. There are a few cases where you can have a recessive disorders associated with some of these genes, but like ALG9 or IFT140, but this is an exception for the moment. We know that this is a change. When you change name, it's a big change, and we will need to educate stakeholders, people, families, the healthcare providers, but also the insurance companies regarding these new names and what they mean in terms of disease characteristics. We also need to keep in mind that there is a big familial heterogeneity, intrafamilial heterogeneity in ADPKD, which can modulate the presentation of the disease, of course. So at this stage, I would like to ask first multiple choice question for you, which is related to the diagnosis of the disease. So this is a case, a 50-year-old man with 3 bilateral cysts discovered on routine ultrasound. There is no family history of cystic kidneys. The GFR is 70. The blood pressure is 135/85 office seated. And so we ask you if you can see the different proposals. Is the diagnosis of ADPKD is uncertain, unlikely, if it needs further genetic testing, if it needs MRI, or if you need a family history more in detail. So please vote.
So the poll is open, and we wait another 30 seconds. Another 10 seconds.
Okay, I guess you can't see the poll results, Olivier, so I read them out to you. There's 12% for diagnosis of ADPKD is uncertain, 26% for unlikely. There's 42% who want to go for genetic testing, 5% for an MRI, and 16% who are convinced that it needs family history for ADPKD.
Yeah, very good. So we fully agree with this with these responses. So the diagnosis is unlikely, in fact, because you see the number of cysts is small for the age, the blood pressure is normal, kidney function is not really modified. So yeah, number 2, unlikely, or further genetic testing could be proposed. Yeah, many people would like to do genetic testing to exclude the diagnosis, but in fact, with routine ultrasound, you can already exclude the disease, as I will say in a moment. Okay. So the clinical diagnosis of ADPKD is typically associated with bilateral kidney cysts. Usually there is kidney enlargement, often there are liver cysts, and extrarenal manifestations, including number 1 hypertension, which is very early in the disease course, of course. The absence of findings suggests are important, and the family is not necessary to have a clinical diagnosis of ADPKD. So in case there is a family history, so family history must be investigated at time of contact. In case there is a positive family history and the genetics has been found, it's very easy because you can just do allele-specific genetic testing, or if the person does not want genetic testing, you can do an ultrasound, a simple kidney ultrasound, and you can progress. You can confirm the diagnosis, or you can exclude the diagnosis in the at-risk family member. If the family is not resolved in terms of genetics, first you can confirm the diagnosis by ultrasound, and there are criteria you see on the right hand. I will not go over the criteria which are based on the number of cysts, or you can go for genetic testing, like many of you were responding in the question. The genetic testing, depending on some criteria, will help you to have a positive diagnosis or to exclude the diagnosis of ADPKD. What is more difficult is when there is no family history of ADPKD. It's an accidental discovery that you should always the question the patient, or if the family history is negative, you propose ultrasound if family members are available, particularly if they are advanced in age. And then, depending on the findings on the ultrasound, you can have a diagnosis of ADPKD or not, depending on the number of cysts, like I showed in the previous slide. If the findings are atypical on ultrasound or any imaging modality, you can go to MRI, which is more precise, or you can go to genetic testing to confirm the diagnosis. Globally speaking, there is a trend now to propose genetic testing in ADPKD. There are many different situations where you can propose genetic testing. Of course, when you have a limited number of cysts or the family history is negative, this can be very informative. Forget that to analyze, you may find some diseases which require specific testing. In case of related living donation, it's very important with familial variant or any other genetic cause. Family planning also is increasingly sought in ADPKD, so genetic is a prerequisite. And in all people, genetic testing will allow a more precise diagnosis and a prognostic information, as I will mention in a moment. And here I just mentioned this recent study from the New England, where having a genetic diagnosis can improve the clinical care in some people, ends the diagnostic odyssey, and helps for prognosis and counseling. So I think we go towards genetic testing when there is a suspicion, and there are many benefits. Now, if we look at the clinical course of ADPKD, as you know, the disease is characterized by multiple cysts and progressive growth of the kidneys. The growth is exponential, is individual, is highly variable, approximately 5% increase in total kidney volume per year. And you can modelize growth because of the exponential nature of the progression. If you populate the kidney volume in blue on this slide with the GFR in red, you can see at the beginning that the total kidney volume is increasing first, and the GFR is relatively stable, and then will go down. But the two measures are correlated which led the regulatory authorities in the US, the FDA, and in Europe, the EMA, to accept the total kidney volume as a function of age, as a surrogate or prognostic biomarker to identify a patient at risk of progression in the disease. And you know very well that in the clinical trials for ADPKD, the total kidney volume was considered as an endpoint in several trials. However, the total kidney volume has some limitations. We should never forget that. For instance, on the left, you can see a PKD1 mutations, which is associated with only a few large cysts, and the kidney function is still normal. Whereas on the right hand, you see again a PKD1 mutations associated with very small atrophic kidneys, where the kidney function is, total kidney volume will be normal, but the kidney function is defective. So the direct correlation between total kidney volume and kidney function is not always observed. So the most used marker for kidney disease progression is the total kidney volume, as I mentioned before, obtained by MRI or CT scan, but there are more studies on using MRI. And this is the famous Mayo imaging classification, or MIC. What we want to remind is that this Mayo imaging classification can only be done in case of typical ADPKD, like you can see on the panel 1A and 1E on the top here. You can see you have a multiple number of cysts, and the disease is relatively homogeneous on the two sides. In that case, you calculate the total kidney volume, you normalize for the age, and then according to age, you have this normogram that is really reflected by the survival, the kidney survival. And of course, patients with very small kidneys for age have a much better prognosis than those with very large kidneys. But you can see that there are many situations where the MRI imaging will be atypical, and in that case, the Mayo imaging classification has not been validated. It's quite important to remember that. You can estimate that approximately 80% of the patients will be in the typical category, depending on the type of referral center you are working in. To identify rapidly progressive patients, we recommend to use the Mayo imaging class, because this is the system that has been validated most, provided you have a typical image. But there are other biomarkers or factors that can be integrated. So the genetic testing, the type of mutation, I will mention briefly another type of score, the ProPKD score, which is integrating genetics. The family history, you can ask the patients in your family at which age the patients were on dialysis or transplanted. This can be an idea of the progression in the family. You can see the eGFR decline, and the other types of markers have not been established. So those are relatively classical prognostic indicators. So again, regarding the total kidney volume, the measurement of the total kidney volume can be done in different ways. The planimetry, which is the gold standard, is very time consuming, but nowadays with image analysis and machine learning, these tools will become very quick. So the ellipsoid, etc., will become outdated quite soon, and many centers already are using algorithms to measure total kidney volume. So this is not a problem anymore. The prognosis can be indicated by the type of mutations, and you can see on this survival curve. So for instance, if you have a PKD2 mutation in red, your survival would be much longer than a PKD1 truncating mutation in yellow. So the type of PKD1 mutation or PKD2 is a strong prognostic factor in ADPKD. Again, those are global curves, and it's sometimes difficult to make individual predictions. the myoimaging classification I showed you before, this is based on TKV. So genetics and TKV, total kidney volume, are really strong prognostic indicators in the disease. Another tool has been the PRO-PK score, which is essentially based on gender, type of mutations, and some complications of polycystic kidney disease like hypertension and urologic complications like kidney stones. Depending on these factors, clinical and genetic factors, you get points. And according to the number of points, you have 3 categories: low, intermediate, and high risk of progression. The PRO-PKD score is used in some places where the genetic information has been accumulated over time, like for instance in France, where genetic testing was reimbursed early on. If we look at the life journey and the therapeutic options in ADPKD, we discussed before that there is a progressive increase in total kidney volume, a progressive decrease in eGFR. You can see at the bottom the main complications, the clinical complications. You see hypertension is starting very early, and actually even in childhood, there are some indicators of hypertension. Pain can also be relatively early on in the disease. And then in green, you have the different therapeutic interventions. So we don't have a lot to propose at the beginning of the disease course. Lifestyle, of course, some dietary sodium restriction. Then when hypertension is there, of course, you should aggressively treat. Any systolic blood pressure over 130 should be corrected. The pain management, we will say a word about that. A sizable fraction of the patients have pain in the lumbar region, so there are different methods to treat the pain. And then Tolvaptan will come at some point. We will discuss also very briefly now some issues regarding dialysis and transplantation. So first, hypertension. Hypertension is very common. The vast majority of patients with ADPKD have hypertension. As I said before, it probably starts already in childhood. So the management of hypertension and the monitoring are relatively standard. They are reflected in the KDIGO guideline for blood pressure in CKD. The targets are indicated here. They are relatively strict. Below 110/75 if kidney function is normal and if the patient is less than 50-year-old. So, and of course, you may have individualized targets depending on the clinical state of the patient. Kidney complications of ADPKD are well known. You have kidney stones, you can have gout, hematuria, macroscopic hematuria. Renal cell carcinoma is not definitively associated with ADPKD. There are conflicting data. It's important to know it's not established, and urinary tract infection can also occur. So the management of all these complications is relatively standard, except of course for urinary tract infection. If you have pyelonephritis or cyst infection, you will need a very long course of antibiotic therapy and a choice of right antibiotics, as I will say before. Kidney cyst infection, so you have clinical factors, microbiology, imaging, and response to treatment, which are important. You see here the key points. The antibiotic therapy should be long, more than 4 weeks, and you should use a lipid-soluble antibiotic for this very specific complication. The pain we mentioned before. So for the pain, we propose a stepwise approach that can be extremely problematic in some patients where the pain is really a big problem. So you can start with non-invasive, and then you can step up using more aggressive therapies and even invasive therapies in some cases. So this is a typical issue of shared decision making, and the guidelines will propose different approach based on this global strategy. Dialysis, this is a big issue. Many clinicians still believe that peritoneal dialysis is excluded if you have polycystic kidney disease. We did a very comprehensive review of the evidence, and this is not the case. The selection of dialysis modality should be determined by patient-related factors, choice, and availability of facilities. So peritoneal dialysis should be considered as a viable replacement therapy. The caution will be indicated only when there is massive kidney and or liver enlargement, or when there are standard contraindication to PD. So PD can be a valuable option in ADPKD. Kidney transplantation, so there are some specific issues and complications that we mentioned in the guidelines. For instance, one which seems to be quite trivial, but which is important, is the kidney and the liver weights should be subtracted from body weight when you estimate the BMI. So patients could be excluded for a very high BMI, but in fact, it's due to the weight of the kidney or the liver. So I will show you in a minute how you can do this calculation. It's important to do an abdominal MRI within a year of at least inscription to the waiting list and renew that if this is extended. Native nephrectomy is indicated in case of infection, bleeding, kidney stones, pain, of course, or if the kidneys are massive. The approach to native nephrectomy is important. It should be done at time or after transplantation rather than before. And we advise laparoscopy rather than open nephrectomy, and unilateral, of course, if possible. The complication post-transplantations are more common in ADPKD, and you see, for instance, new onset diabetes, NOD, erythrocytosis, some vascular complication, cyst infections can be observed, but those are relatively small series and still more evidence is needed. But you see, caution should be taken. So this is the formula to adjust the body mass index. So you need to subtract total kidney volume and total liver volume in kilogram estimated from the volume. And then you add the weight of a normal kidney or liver, and numbers are available for normal kidneys and liver. There are some websites which we give, but you have some estimations also, which are given here in numbers. What about Tolvaptan? Tolvaptan is today the sole therapeutic intervention that has been shown to modify or to slow down the course of the disease. This is based on two RCTs, one Tempo 3-4 published in 2012 and the second reprise published in 2017. The two populations were different in these studies. The conclusions were positive for Tolvaptan, but of course associated with side effects, which are aquaretic side effects, and also the risk of abnormal liver function test in 5% of the patients, which will require some specific precautions. So the indications for Tolvaptan are for patients with rapidly progressive ADPKD. So it should be offered to adults with EGFR above 25 and risk of rapid disease progression as indicated by the Mayo class 1C to 1E, or an historical rate of EGFR decline above 3 ml per year if you have repeated measurements. So it's quite precise, the indication of Tolvaptan. You have to discuss with the patients the benefits, the harms, and the uncertainties. For instance, so far there is no study showing that Tolvaptan delay the onset of kidney failure. We have very few long-term tolerability studies, and we have very few studies on the effect of increased endogenous vasopressin levels, which are characteristic of the use of Tolvaptan. So this balance should be discussed with the patients. There are absolute and relative contraindications of Tolvaptan, but you are probably very familiar with them. What is really important is titration approach, starting with 45-15, and then after at least 1 week, you increase progressively to 60-30 and then to 90-30. The approach is trying to get the highest tolerable dose of Tolvaptan. You can down titrate Tolvaptan in specific situations linked to the tolerability, the use of CYP3A inhibitors, or in case of abnormal liver function test. But in that case, you should really take specific precautions. So, and that leads us to the second multiple choice question that I will read for you. A female patient, 45-year-old, is treated by Tolvaptan 90 to 30 milligram daily since 1 year, 12 months. The routine labs reveal AST 110, normal value is 8 to 33. ALT 145, normal value is 4 to 36. And a total bilirubin at 3 milligram per deciliter. So what do? You decrease the dosage of Tolvaptan to 45-15, and you check the liver function test within 72 hours. You repeat the liver function test within 6 days. You ask for liver ultrasound and for repeating LFT. You stop Tolvaptan and you repeat LFT within 72 hours, or you organize a consultation with the gastroenterologist. So you have 5 options.
So the poll is open. You have another 40 to 60 seconds. We have 10 more seconds.
All right, the answers are 25% want to decrease Tolvaptan to 45 and 50 milligrams and check again LFT within 72 hours. 10% want to repeat LFT within 6 days. 10% ask for liver ultrasound and repeat LFT. 55% would stop Tolvaptan and repeat LFT within 72 hours, and nobody actually wants to meet up with a gastroenterologist.
Okay, thank you, Jens. Okay, so yeah, the majority is right. So we should stop Tolvaptan and repeat LFT. You see the increase in liver enzymes is more than 3 times the upper normal limit. So in that case, very clearly, we propose to, you see, we are in this left, to permanently discontinue Tolvaptan, unless, of course, there is another reason for liver toxicity, liver injury. So you have to take that seriously, and of course, when you start to prescribe Tolvaptan, you should first measure the baseline liver function, and then there are mandatory requirements like a monthly test for the first 18 months, and later on you can relax a little bit every 3 months. The vast majority of liver problems have been observed relatively early in the course of Tolvaptan. This is explaining why there is this 18-month threshold. In the question, I put 12 months just to catch your attention on this time limit. So the attitude in case of potential liver toxicity with Tolvaptan depends on the magnitude of delta of the liver function test. So in that case, the clinical case, it was more than 3 times, so then you stop Tolvaptan. If it's less, then you hold Tolvaptan and then you repeat the testing relatively early, 2 or 3 days, and then you decide what you do, depending on the evolution of the liver function test. In the experience, most of the time, the liver function test will decrease, because sometimes there are intercurrent liver toxicity, which are not always easy to find out. It could be a big dinner, it could be some other drugs, but the real toxicity cases are relatively rare. So it's important. We do not advise to re-challenge. Because there has been a safety pool of almost 3,000 people who have been re-challenged, and you can see that return of toxicity has been observed in a vast majority of cases. So it's important not to re-challenge your patients if you have a high level of enzyme when you reinitiate Tolvaptan. What about the other measures? So water intake, classically we advise to increase the water intake to at least 2 to 3 liters per day if it's comfortable for people. Of course, the contraindications of high water intake are particularly due to urologic problems or difficulties to void. But if this is not the case, you should really advise your patients to drink a lot. And then we do not advise to use other drugs, although some of them are currently tested in ADPKD. So the mTOR inhibitors have been tested before and they were shown signs of toxicity. Metformin currently tested. Statin, questionable results. SGLT2 inhibitors, they are ongoing trials. Somatostatin analogs are useful for liver, enlarged liver, but not on the long term for the kidney. And ketogenic interventions are very popular, but they are not supported by robust human evidence at the time, but ongoing clinical trials will give an answer quite soon. So, but at the moment, you should rather discourage your patients to take medications when it's not proven, when the clinical efficacy is not proven. What about polycystic liver disease? So it's very important to explain this very frequent complication or association to the patients. Most patients hopefully have no symptoms and require no treatment. The hepatocellular function remains normal. However, there can be some clinical manifestations shown here. So there is a volume effect with pressure against the diaphragm and in the abdomen. And against the stomach, and you can have some complications of the liver cysts like infections or hemorrhage, and sometimes you can have portal hypertension. What is really important in women, this association polycystic liver disease is earlier and more severe and more frequent in women than in men. And this is dependent on estrogen impregnation. So depending on the severity of polycystic liver disease, there will be recommendations in terms of contraception. And you can see on this cartoon, if there is no or mild, very mild polycystic liver disease, you can use combined low-dose estrogen progestin. If it's moderate or severe, then you can really, you have to stop the estrogen and more likely use an intrauterine device rather than an oral administration of any type of hormone. There is also increasing awareness about in vitro fertilization and polycystic liver disease or aggravation due to the high dose of estrogen that are given for ovulation strategies. So this is becoming a problem, and actually a polycystic liver disease, moderate or severe, is a contraindication of IVF. At least it should be discussed very carefully with your patients. So, and we come to the third question. So the following extrarenal manifestations are associated with ADPKD: intracranial aneurysm, situs inversus, sperm abnormalities, colonic diverticulosis, all the above.
You have another 20 seconds.
All right, we have the answers that 29% see intracranial aneurysms associated with ADPKD, none cetus inversus, 5% for sperm abnormalities, and 66% for all of the above.
Yes, thank you. Yes, I mean, vast majority, all of the above. In fact, yeah, all these complications are associated with ADPKD, including cetus inversus and sperm abnormalities. And this is something interesting to see that some of you did not know that, and but those are, of course, very rare complications, associations, I should say. So first of all, intracranial aneurysm. So that is a classical complications of ADPKD. You can see here the prevalence is about fourfold. The risk factor are family history, again, very important, but also the other classical factors like smoking, hypertension, PKD1, female sex seems to be associated, the severity of the disease in general, ethanol, and some ancestries. You should always tell to your patients that most intracranial aneurysms do not rupture. And the risk of rupture is depending on the size of the aneurysm and the location and the risk factor, including particularly, of course, smoking and blood pressure control. So I think this type of conversation is absolutely essential to have with your patient. So there are recommendations and practice points for screening because this is a very hot topic in ADPKD, and a lot of patients are anxious. So we spend, the work group spend a lot of time to discuss. Information is absolutely necessary. All patients should be informed. Screening is recommended if there is, of course, a personal or familial history. And if the patients are eligible for treatment and have a reasonable life expectancy. You should discuss screening if there is a de novo, if the familial history is not known or it's a very small family, if there is a family of extracerebral vascular phenotype like thoracic aneurysm or anything like that, and in particular clinical settings like prevision for a major surgery or evaluation for transplantation. Some people, they really want to be screened, and then you should absolutely discuss with them and offer the screening. If the screening is negative, it should be done again after 5 to 10 years, depending on the risk factor. And when there are intracranial aneurysm or one is found, management should be done in a specialized center used to treat this type of complication. There are advantages and limitations of the screening. So of course, if you discover something, you may act, you may also follow, and you may also discuss the size and the location. And the limitations is that, of course, it can cause anxiety. It may limit access to some insurance and even work opportunities if you have an intracranial aneurysm. And then it may induce therapeutic actions which can induce complications. So it's something serious to discuss with the patients before the screen. You should absolutely explain what are the manifestations of rupture, which are the famous thunderclap headache. And we explain, and we show this very nice cartoon, and to explain to the patients when they have this sudden onset of pain, they should really go to a medical center and seek medical attention. The extrarenal manifestations are listed in the guidelines, and this was really extensive, and you will see that there are many associations that have been reported, some of them very rare, but still there. You can see the sperm abnormality, situs inversus, particularly with PKD2, and of course, colonic diverticulae have all been associated with ADPKD. A very important aspect is women with ADPKD, and I got these slides from Rosa Tora, who gave a very nice lecture about this and was really instrumental for the work group. So we already discussed the big issue is polycystic liver disease and the role of natural and external hormones, particularly estrogen. There is also the big issue of preconceptional counseling and reproductive counseling, which is increasingly requested by this patient. And the pregnancies in ADPKD are considered of potential high risk. And this is really important, you see, to discuss and be informed. So the reproductive options, of course, should be discussed with the patients. So you may discuss to do nothing. So then the chance is 50% to have a newborn with ADPKD. Sperm or egg donation is another option. Pre-implantation genetic testing, PGT, is possible when the genetics is clear. Then you can select, of course, the embryo and perform an in vitro fertilization. But we discuss if there is polycystic liver disease, this procedure is dangerous. And then the prenatal testing, if the parents would consider pregnancy termination in case of positive diagnosis. So all these options should be discussed with, when there is reproductive plans. You can see that specific measures have been are advised to discuss with women of childbearing age, including hormone therapy, preconception, management of the pregnancy, and after pregnancy. Where there are some complications I just mentioned, also Tolvaptan should be stopped in advance because it's potentially teratogenic, like of course the inhibitors of the renin-angiotensin system. So there are also some issues with bladder instability and urinary incontinence, which are quite frequent in women with ADPKD, the risk of urinary tract infection. And also there is a higher risk of preeclampsia, indicating a low dose aspirin from week 12 to 36, which is recommended for pregnant ADPKD women. So there are a lot of important points which are also included in the guidelines. So I will finish now by a few issues that are not often discussed, but which were considered as extremely important, is the stress associated with ADPKD. There are physical stressors which are due to the volume of the organs and the physical conditions, but there are many other fears which are important to consider and remember as healthcare professionals. So the family issues, the genetics, the inherited nature of the disease, and the social stressors with the cost of the treatment, the inability or the difficulties to make plans. So all of that should be considered, and many of these issues are encountered in other genetic disease and are extremely important to keep in mind. We also propose a care pathway where from the diagnosis to the follow-up, the dialysis and replacement therapy and the research, we propose an ideal setting to take care of patients with ADPKD. And this is very important because nowadays some European guidelines, for instance, will try to promote care pathways for a genetic disease, and this effort could be implemented in many European countries and will be discussed with European authorities. And the final slide, one of the final slides, I dedicate this slide to the memory of Tess Harris, who was member of the work group and deceased from polycystic kidney disease and transplantation earlier this year. Tess was really an advocate for polycystic kidney disease, the patient consideration, and she came also with this very important concept of share seek patient participation, help patients to explore and compare treatment options, assess the preference and the value, reach the decision with the patients, and evaluate the decision. And so the patient-physician interaction is of major importance. It should never be forgotten. So the memory of tests led me to indicate that many patients' organizations were involved in these guidelines. And you see in many countries, you have patient organizations that can be recommended and indicated to your patients, and they speak the same language, and they will facilitate acceptance and give practical advice for those affected by the disease. And also, I had no time to discuss the pediatric issues, but there will be many pediatric issues included in the guideline. There is a whole chapter, and Jalila Mekali is also speaking very often about this. It's a new aspect of ADPKD, and there are no evidence that children should also be considered for early manifestations of the disease, and sometimes very early, as you can see, cystic and phenotypes. I would like to finish by thanking all people that have been involved, including the KDIGO staff and you all for your attention. Thank you.
Thank you very much, Olivier. And first of all, thanks for putting so much work in that tremendous guideline. Thanks to you and the guideline group. And thanks for pointing out the main points here within these 45 minutes we had. Before I would like to read out the questions, I'd like to apologize for the audio issues that we had in between. I think we still were able to get the main messages. And we have several questions, and lots of them come from Sybil Gokchai-Bik. I hope I pronounce it correctly. Thanks for that. And the first question she raised was, she said things or points out that we need more genetic studies to understand the specific mechanisms of the cystic kidney diseases. And she asked, do you advise or should we advise genetic testing for all patients with ADPKD or ADPLD and other cystic kidney diseases? I think there are not only a few types, but there are a spectrum of different diseases.
Yes, thank you for this question. I'm really, again, very sorry for the audio, but I don't think it's my fault. It's the line between Switzerland and Europe, probably.
Absolutely.
Yeah. So, in theory, genetic testing will become cheaper and cheaper, but please don't forget that interpretation of genetic testing remains difficult. There are many cases where the variants are not clearly causal, or causality is difficult to ascertain. And when we prepare these guidelines and when we discussed, the views on genetics is not homogeneous. In some parts of the world, even in the United States, for instance, there is a lot of people say the diagnosis of ADPKD is clinical, it's imaging, point. So genetics is not necessarily needed unless they are a very clear need, like for instance living donation or atypical cases, etc. So I tend to agree that genetics will be probably will become an essential part of the workup. It's not always easy to have access. There are still difficulties in the interpretation, but probably with time, the interpretation will be easier and easier because many more patients will be tested. Yes, so I agree, but you have to know that the vision about that is still controversial.
Thanks a lot. Then there's another question. I think you had a slide on that already and pointed out that AI helps in the volume calculation of kidney volume, total kidney volume already. Do you see any other fields where AI could help in predicting the personal diagnosis or prognosis of ADPKD patients?
Yes, also a very good point. So indeed, AI will be used and machine learning will be used for total kidney volume, total liver volume measurements much more quickly. AI is also essential for interpretation of the genetic variants, so the interpretation of genetic testing, because the algorithm will be more and more used with the number of available genetic sequences. So I think another aspect that is currently investigated is the use of AI and machine learning to investigate patterns of kidneys on tissue, on imaging, because when we do MRI, we see a lot of cysts, but in between the cysts, there is kidney tissue. And maybe the patterns of these kidney tissues will give some indication, some prognostic indication. So this is a typical area where imaging, advanced imaging, could really help us to find biomarkers of progression. I do not even mention multi-omics, proteomics in the urine, etc. So there are many situations where AI will help us to refine prognostic indicators.
That's a very interesting point. Thank you very much. Then we have some questions regarding the children and pediatric view, and you just mentioned that at the end. And the first question maybe is a very important one. Is the Mayo classification actually validated for children?
No, it is not stricto sensu, because you realize the difficulty to do MRI in children, because for technical reasons. So there are efforts done by Jalila and an international network to try to validate total kidney volume in children. I don't know exactly how they measure total kidney volume. Is it by MRI or by ultrasound? As a prognostic indicator, it seems that if you take adolescents, after age 10, for instance, yeah, the size of the kidney, the volume of the kidney is an indicator, but this is not yet well validated nor recognized, I believe. But there are current efforts in this.
Yes, I know that Jalila is collecting particularly MRI data from children there in to answer this topic.
Yeah. And Jens, if you allow me, so in low resource settings where MRI are not available, or if it's difficult because of children and ultrasound and the developing technologies in ultrasound are also now increasingly becoming available. And we say in the guidelines that obtaining a kidney size by ultrasound can also be used as a surrogate for total kidney volume. So this is also maybe a way to go forward, to move forward for the children prognostic indicators. Yeah.
Very good point to point out. Yeah, thanks a lot. Talking about adolescents, another question here is, have we started using Tolvaptan routinely in adolescent children with a high risk of progression? And if so, if there's a guide on dosage and titration?
Yeah, that's a very good question. So there is a clinical trial of Tolvaptan in adolescents. Giving Tolvaptan to a child is like nephrogenic diabetes insipidus. So this is, of course, of major issue because they are developing, the urinary tract is developing, and the complications of high urine output could be important. So there is a trial ongoing with the idea to give Tolvaptan in earlier than age 18. At the moment, age 18 is the threshold. You cannot give it. It's not allowed to give it before age 18.
Mm-hmm. Then there's another question regarding the treatment goal for blood pressure for patients above 60 years with ADPKD. That would be below 110/75 as well?
No. No. This very strict threshold was only for people. I think I don't remember exactly the age, but of course less than 60-year-old. For age people, it's an individual decision, but the general target will be below 130/80.
Mm-hmm.
Below, yeah.
Then there's a question regarding the Tolvaptan compliance, which is particularly in younger patients often very low. Do you have any personal hints how to increase compliance?
Yeah, this is a very good point. And indeed, we have done a study showing that particularly young patients like age 35, 40, starting Tolvaptan, they usually have a big response, urinating a lot, and this can be quite disturbing for them in their professional lives, etc. So then the tolerance is lower. So there are several ways to prepare that. First of all, don't forget to advise to drink at least 2 to 3 liters, because this is really preparing the patients very well. Usually we advise to discuss very openly the complications, like for instance, long daily trips to go to work in the car, if you are on the highway, etc. All these practical issues should be discussed with the patients. And we know that the young professionals are at risk of stopping the treatment or taking the holidays of treatment. So we don't like, sometimes they stop treatment for weeks, which is not really a good idea, because then the kidney is exposed to on-off effect of vasopressin. So it requires Tolvaptan adherence is requiring a careful discussion with the patients, starting with high water intake and explaining the strategies to try to minimize the nocturia, because the nocturia is the most important problem. So it's important to start the treatment, to take the first dosage very early in the morning, like 7 o'clock, and then the second dose of the day in early afternoon. This will minimize already the nicturia, which is often considered as a problem.
There are another 2 questions regarding Tolvaptan use. One is the use of Tolvaptan restricted to PKD1 and PKD2 variants, or can it be used as well with variants in minor genes? And the second question is a very interesting one as well. Is Tolvaptan teratogenic if it's used in males? So has it effects on the sperm quality as well?
Yeah, very good. So for the second question, no, absolutely no evidence for Tolvaptan effect on sperm. So it's interesting to know that polycystic kidney disease has an effect on sperm mobility, but not on fertility. Demonstrated. Tolvaptan on PKD1, PKD2 only. Actually, the clinical studies did not include genotyping. So we believe that a few percentage of the patients included in the clinical trials were not PKD1 or PKD2, probably. So I had exactly the same questions a few months ago, where one of my patients with typical ADPKD was not PKD1 or PKD2. So should I give Tolvaptan? So we say yes, because the disease process is probably relatively apparented. So if you have typical ADPKD with the criteria for rapid progression, which are based on total kidney volume, you could prescribe Tolvaptan.
Thank you very much for that answer. Then I have 2 questions regarding typical complications of ADPKD. One is, how do you manage patients with gross hematuria and suspected ruptured cysts? Hospitalization, perform a CT scan, and which therapy, and antibiotics. And then the second question was, how do you treat ADPKD patients with recurrent UTI?
So the treatment of recurrent UTI is the same. Then the recommendations are similar for recurrent UTI. Low prophylaxis if necessary, precautions for hygiene, etc. So this is not different from recurrent UTI in the general population. Gross hematuria is rest imaging, of course, excluding cyst infection. So which is, the question of antibiotics. But yeah, perfusion if necessary, but there is no very other specific treatment that has shown efficacy. Rest is the most important. Imaging is important because by MRI you could see if a specific cyst is bleeding. if you compare to the historical imaging, and if the hematuria is really sustained, which is a very rare, then of course you could discuss more aggressive options.
All right, and as it's 5:10 already, I'd suggest that we raise the last question here, which would be any place for kidney coiling after kidney transplantation if there's mechanical complaints and if nephrectomy is considered too risky.
I mean, embolization, embolization is also considered in the guidelines. There were discussions about that because it appears it's really the center effect is major. Center effect is, so if there is expertise in the center, yes, embolization can be performed, of course, to decrease the total kidney volume.
Okay. Yeah, thanks a lot, Olivier. I wrote out a lot of questions to you right now. I didn't read out all the feedback that says a lot of great talk, and thank you so much. I think we can just emphasize that as well. We've learned a lot from your talk, and it was fantastic. And thanks to all in the audience for raising so many questions. And at this point, I would suggest we stop here, and I wish all of you a great night tonight. Thanks again, Olivier.
Thank you very much, Jens. Thanks to you all. And you will have many information in the complete guidelines early next year. Thank you.
Thank you.